Good evening and welcome to EASL Studio, your weekly hepatology broadcast news. In tonight's episode, we'll discuss Alpha-1-antitrypsin deficiency. If I look back on my career, we haven't paid much attention to it and generally perceived maybe something with the kids and not something we consider that much about. But that is actually turning out to be wrong. There's an explosion, I think, in knowledge, the new understanding of how we diagnose it, when to diagnose, how to monitor, but also a lot of exciting stuff in new drug developments. So this we're going to discuss, and I'm so privileged. My name is Aleksander Krag, hepatologist based in Odense. I'll moderate this session, and with me I have Pavel Strnad from Aachen in Germany, Alice Turner from Birmingham, and Aftab from London. So welcome. So maybe guys, I can have you a quick round here. So tell me one by one, why is this important and why should I be interested in alpha-1 antitrypsin deficiency as a hepatologist? Maybe I can start with you, Pavel.
Well, it's a greatly underdiagnosed disease where we actually now, due to the drug development, can really do something and where we can change the life of our patients. So that's why we have to get better for them.
Okay, underdiagnosed, new opportunities. I'll get back to that. Alice, from your point of view, you're a pulmonologist, so a bit of a stranger in our land, but from your perspective, what is it really that makes this very important to know something about?
So, I mean, I guess what you guys in liver maybe can learn from us in respiratory pulmonology in Europe, of course, is some lessons about what happens with underdiagnosis, new drug development, the difficulties of selecting outcomes for trials in this population and running trials in this population. So I see it as like an opportunity for us to learn from one another. And for me, as a pulmonologist, I have started to look at livers more, mainly since Pavel told me how to do it well. And I have found way more liver disease in my population once I've started looking properly. So now that I understand that, I think I'm doing better. And I hope that by working together, we can generally improve for our patients.
That's wonderful. I love learning from each other. And here you have a good opportunity to teach the liver people around. So Aftab, from your perspective, why is this important? What is it really we should focus on?
This is a great passion of mine, and certainly I believe that there's a big unmet need in improving our awareness as a community, both of liver disease itself, but also of the disease-modifying effect of the alpha-1 antitrypsin, and the fact that a number of patients go undiagnosed for a number of years, and the fact that we really need to do more to test and to diagnose, and particularly for considering the possibility of family screening and genetic screening.
Interesting. Okay, let me try to pick on that. So I already learned here that underdiagnosed, missed opportunities, that sounds as if we have room for improvement. Then let me get back to you, Pavel, then. Okay, then tell me, how should I assess for it and who should I look for this in? Which patient group?
So what is important that you cannot recognize a patient with alpha-1 antitrypsin deficiency just by looking at them. So they can present with a liver disease, they can present with a lung disease, they can have some risk factors for liver disease, so they can be obese, they can be diabetic. So you basically need to check every lung and liver disease patient not to miss it, because we all know that that amount of alcohol consumption is difficult to say and so on. So
how do we assess? So now we get a little bit closer to who we can expand on that, but how do you do it?
So it's nothing is as simple as that. So you basically start with measuring the alpha-1 antitrypsin serum level. And if this is decreased, you know that that something is going on. And even if it's a borderline, like at the lower limit of normal, this can be a mild alpha-1 antitrypsin deficiency. So you get a very cheap first test. And if this is indicative of something going on, you continue with either genetic or a combination of genetic and kind of protein analysis called called phenotyping.
Okay, so your first level, say, we can expand a little bit. So you would look at patients or people coming to you that is under suspicion of liver disease. So let's have an abnormal liver function test or something that will make you, and then you will, but we can get back to Alice there with the lungs. But Aftab, you said a little bit about genetic screening. Screening, that's a different approach then. So from your perspective, how do we best find these patients? And again, if they're underdiagnosed, they often emerge too late in the healthcare system. So what is your current practice and what would you like to see improved?
I really would like to see the family screening aspect of this improved, which we can do much better. So, for example, if a index patient is diagnosed, it's really critical that the remaining, particularly the siblings, get tested. There are instances in which, as Pavel was alluding to, where you have got members who've got history of, for example, alcohol-related disease or features of metabolic syndrome, where those are also important to test for alpha-1. And it can be very often, particularly in the busy clinic, just to miss or to not necessarily pay attention to the borderline alpha-1 cases. So those are, you really have to have a high index of suspicion and really be critical on yourself and not missing that diagnosis, and really pay attention to that patient as well as the family members, because that's where you are the gatekeeper in some of those respects. So it's particularly...
That makes sense. So, but we'll get back to the different genotypes, but I think that just to make it clear for the family screening, would you do that only in those with ZZ genotype or other genotypes also?
You'd consider in the other genotypes. So, for example, the three genotypes. Obviously, the ZZ is the one that we particularly are worried about in liver, SZ and MZ, particularly MZ, where we need to be more mindful of other associated, particularly modifying factors, which we often overlook.
Hey, then to you, Alice, when does a pulmonologist look for alpha-1 antitrypsin deficiency? And afterward, I'll ask you, when do you look for the liver? But start there. Which patient should you look for or screen for it?
So essentially, anybody who has symptoms of COPD, so long-standing breathlessness, progressive breathlessness, cough, sputum, regular chest infections, and in particular, if you see that with a lower smoking history than what you would otherwise expect, or a family history. And in the European Respiratory Society guidelines, we say family screen anybody who's got 2 abnormal genes. So not just ZZ, ZZ patients, but SZ patients, we would test their siblings, potentially parents and children. We generally don't go wider than that because it's if we did that, we would be screening so many people. We have to remember that 1 in 25 Caucasian people are a carrier for alpha-1. So, that could mean that we're testing ad infinitum.
Hey, very interesting. So when would you test then for the liver? Who do you look in for the liver then?
Personally, I screen everybody who comes to the clinic with FibroScan the first time that they come, if they've got 2 abnormal genes. So if they're ZZ or SZ patients, I FibroScan, and I would, if they're abnormal, if the FibroScan's abnormal, I would think about doing ELF test or taking advice from one of my liver colleagues.
Maybe
and obviously they all get blood tests.
Okay, yeah, we can come back to a little bit. How do we use the non-invasive test? And Pavel also know a lot about that, and Aftab also. But you mentioned the guidelines. What is your impression of people's adherence to these guidelines? I would say just here, I can say I don't always do it. It's a bit embarrassing here to admit it, but I will improve.
Yeah, I agree. None of us do what we're told all the time, right? So I think they're there as a helpful guide for us to come back to remind us when we need to, what we need to do. So it's helpful to have these documents online to remind us.
Yeah. Okay, so
obviously,
yeah, please, Pavel.
We don't have a liver guideline, right? So that makes it even more difficult. So we are working on it. One more thing I wanted to say, just the very simplest thing. So an alpha-1 antitrypsin patient should have normal liver enzymes. So whoever comes to you with recurrently elevated liver enzymes, you really need to check the fibrosis and everything, because actually 90% of alpha-1 patients have normal liver enzymes. And if they don't, you have to dig deeper.
Okay, Pavel, can I ask you to do super simple there? So with the genotyping, so we said you have these with decreased levels in the blood, there we will do genetic testing. But how do you then interpret it just to make it in different groups?
So basically what we call severe alpha-1 antitrypsin deficiency is to 95% a ZZ genotype, which means two Z mutations, a homozygous Z mutation. So this is what has like 30 times or 20 times increased risk of lung and liver disease. And everything else from the common genotypes is less severe. The MZ, which is one Z mutation, is 1 in 25, as Alice said. And this is a disease modifier which has maybe twice increased risk of liver cirrhosis. And SZ, it's a combination of one small and one kind of large mutation. This is somewhere in the middle, maybe 3 to 4 times increased risks. So these are the three genotypes, and if you keep them, forget about the 100 other ones, because that's beyond the scope.
Okay, so Aftab, in your outpatient clinic, which of these patients do you follow? Because again, this can quite easy if you do for not just sepsis, but the other a quite frequent thing. And again, it's in many cases not a progressive disease. So who would you follow?
Aleksander, I mean, it's as Pavel said and Alice has said, is that the ZZ ones are the ones that are at significant risk of fibrosis, and particularly those that have got advanced fibrosis and have got high risk of HCC. Those are the ones that we would really would like to follow very, very carefully. The MZ ones are the ones that this is the up and coming the genotype, where those are the modifier risks that there are unmet needs in research into those, how much of a contribution the modifier clinical syndromes or metabolic syndrome have an effect on the course and natural history of that condition. And then of course the SZ, again, unmet need. We could do a lot more in gaining an understanding of those. But in order, certainly the ZZs are the ones in the liver clinic which we are particularly concerned about, and which have got high risk of progression, particularly with the fibrosis and HCC.
So in lack of any guidance document from the societies, and that's of course something I can take with me as EASL, we should consider. But what is your recommended in terms of how frequent to see the patients and what to follow them with? So what measures do you use to monitor the liver disease?
That's an interesting question, because in terms of obviously we have all, it's like going into a toy shop and getting we have all the utilities available to us, including blood testing, FibroScan. So at the moment, certainly FibroScan is the available simple tool that we have. But again, in terms of natural history studies, gaining an understanding of whether there's a true correlation between advanced fibrosis and what's actually going on in the liver, that remains to be determined. But that's probably the best thing that we have.
So how often do you see them, and how often would you perform a FibroScan? Of course, an index scan, but let's say the follow-up work becomes a little more difficult too, because there's not much data. But what is your recommendation?
Certainly, if patients have got advanced fibrosis or cirrhotic even, then I would see them at least every 6 months because of the risk of HCC and complications.
Okay, but over to you, Alice, from a lung perspective. In which part is the liver guy's worst? What is most important for us to know about the lungs and this? And I think in particular, when is it we are not good enough at managing this, and how should we assess lung function in patients at risk of lung disease or lung phenotype?
I think it's helpful to do a set of full lung function when a patient is first diagnosed. So by that, I mean spirometry, but also lung volumes and gas transfer. And that will give you a rounded picture of whether there's any physiological evidence of emphysema, the lung disease that they get. After that, as a pulmonologist, I would do their lung function, spirometry, gas transfer every year. Depending on your health system, whether you can organize that yourself as a liver physician and interpret the tests. I guess if we kind of look at it the opposite way around, what I do with my practice where I've got patients who don't have clinically significant liver disease, I organize their FibroScan according to our local guidelines, which would be potentially every 2 years for people who've got mild fibrosis. And I would do that through my clinic, and I would then just take advice when I needed to. And that saves the patient having to come twice. So if you did that with lung function, as long as you know what the numbers mean, that will be patient-centered way of doing it.
So you think that we can manage? I think we should be able to manage to do that, and again, not complicate patients' life too much. So I think so. We need to have what I guess we'll call a more extended lung function test in our view. And when does the patient then need to be seen by a pulmonologist?
I think if they have significant COPD, so an impaired FEV1 less than, say, 80% predicted, that's useful for us to see them. In the UK, probably maybe less than 50% will be considered severe, and they will be the main people that will be seen in secondary care clinics. But I think if you've got a patient with significant liver disease where their lungs are going to need to be well managed in case you ever get to the point where you need to do transplant, better to get in earlier rather than later. And especially around Europe, patients may be able to access augmentation therapy for their lungs, which is disease modifying. So you wouldn't want to miss out on that by not referring to a specialist.
No, because I think that must be the end goal of what we want to do, not miss any opportunity or have a patient that is really not treated as they're supposed to be given the knowledge we have there. So when you do the FibroScan, so when would you refer to or engage, you said about learning, but also manage the patient, when would you refer to a hepatologist based on a FibroScan or whatever assessment? What is your threshold for that?
So I'd say locally with my liver colleagues, things have varied as we've got to know more and more cases, and we've probably become a little bit more tolerant of levels of FibroScan that initially we referred on to the liver clinic, and then realized that these were mild patients and maybe they didn't benefit. So I think anything over 8 FibroScan median score, I would at least have a conversation. But whether I would refer them might depend on other factors, like, for example, age, the severity of their COPD, what other risk factors they had. Because my 75-year-old patient with very severe COPD being palliated for that with a mild fibrosis, that's not really their biggest problem, is it? It's their lung disease. Whereas my 45-year-old with very minimal lung disease and mild fibrosis, that with risk factors for progression, they need to see you guys.
So still there's room for the good doctor and individual judgment and balancing of different things. So that's good. But maybe back to you then, Pavel, because you've done a lot of studies in this. So how do we actually use and interpret the non-invasive test? We can start with the FibroScan. What are the thresholds? What are the data actually there to support FibroScan and different cutoffs?
Well, so the published data are really only cross-sectional, but we have now unpublished data that are finally longitudinal and that clearly show you that the classic non-invasive tests, as you know them, whether it's apnea or FibroScan, that they clearly correlate with liver-related mortality. So that means that if you have a patient with FibroScan below 7.1, this we would think has a F1 FCNO fibrosis, but then this patient basically has CNO risk of developing a liver-related endpoint over, let's say, 3 to 4 years, and vice versa. If you have a patient with a FibroScan over 15, then the risk of liver-related endpoint even in the next 3-4 years is maybe 10-20%. So, and liver-related endpoint, I mean the classic decompensated liver cirrhosis with ascites, varicose bleeding, and all these basically life-threatening events. So, so the data are very clear that that both APRE and FibroScan are extremely good triage tools and can tell you whether you need to see the patient more frequently, less frequently, or potentially whether you can refer it or advise him or her on ongoing clinical trials.
So Pavel, how it's always an issue. We have many different cutoffs for different diseases. Can we apply the cutoffs we already know? Let's say the Baveno cutoffs of 5, 10, 15, or the modified Baveno cutoff of 8 and 12, which I think is what Alice alluded to, or do we need adjustments in the cutoff for the FibroScan? Can you tell me how you use it in your clinical practice?
I think it's not way off, right? So once we will analyze 10,000 of these patients, we will get more and more precise with cutoffs. But it's clear that having a double-digit FibroScan is clearly showing you that something's going on. And having a FibroScan below 7 or below 8, I think this is a little bit arbitrarily, shows you that the patient is reasonably fine. So certainly FibroScan below 5 is kind of everybody's dream. And FibroScan above 10 is something where you really should pay attention to. And between 5 and 10, obviously, this is a little bit difficult to say where is the perfect cutoff, but kind of the rules to apply to Alpha-1, which we know from other diseases.
Okay, so that's good news. We can sort of use this so we can remember. But let's say that there are many places still that does not have a FibroScan machine. Can you then do APRE or let's say FIB4? People really gotten used to use FIB4 in steatotic liver disease. How does FIB4 perform?
So for some reason, APRE seems to be a little bit better than FIB4 for alpha-1 antitrypsin deficiency. Maybe because it's not that much age-related, I don't know, but we feel, so the data we have so far suggests that APRE is pretty much as good or almost as good as FibroScan. So even the Pullman stuff works quite well, and for even much broader kind of triage, it's definitely a great tool.
Okay, Aftab, I would like to return to what I think you alluded a little bit to before, that we know today, let's say many countries, 50% have a BMI above 25, and there's also wide use in my country and certainly also in your country of alcohol use, and also in Germany. So what is the interaction with other risk factors?
Well, of course, Alexander, the diabetes and a raised body mass index, hyperlipidemia, all parts of the metabolic syndrome are critical because we know they can be pro-fibrotic. So those would be the main risk factor, and of course, smoking in people who've got lung disease. So those are the main modifier risk factors in approaching a patient like this.
Okay, but let me say a little bit more. Now we got the diagnosis, we know who to look for, we have the genetic profiles, and we have the non-invasive test. But what would be your standard approach, Aftab, if you have a patient, let's say they have a FibroScan of 13, 45-year-old, only mild COPD. What would be your standard approach for such a patient? Treatment-wise?
Well, I guess this is where the unmet needs are, Alexander. That's one of the reasons we're here, because the biggest unmet need is really what to offer that patient with the liver disease, and how obviously there are modifier factors which I mentioned, for example, the BMI and diabetes control and weight and alcohol. But as far as anything that can modify any regression in liver disease, this is where unmet needs come. This is where the new frontiers in clinical trials opens up. But at this moment in time, there is really nothing concrete that we can offer patients with liver disease other than the modifier risk factors.
So I guess, yeah, we cannot have any specific targeted therapy, but you should say the cofactors, alcohol, parts of the metabolic syndrome, we can certainly manage. And I guess we can also look for complications of cirrhosis. I guess when you're at a certain level, when you think they have cirrhosis, you do recommend screening for HCC and also with varices
and variceal screening.
Absolutely.
And so forth.
So how advanced is it with specific treatment for the lungs, Alice?
So there's for many years there's been replacement therapy known as augmentation for the lung disease, and this, in brief, reduces the progression of emphysema. So it can be helpful in terms of extending life. There's now been at least 3 different studies that have shown roughly the same extension in life expectancy. However, this treatment doesn't hugely impact quality of life, partly because the lung disease is still there. It doesn't make the lung disease go away, but it may reduce the progression of it going forwards.
Okay, so we are not there yet. But then let's come to it. So still, this is really exciting times, because I guess 10, 15 years ago, many of us would not really expect that there will be a lot of new therapies that could actually manage genetic diseases there. I don't know, Pavel, maybe you can open it up. You were lead author of one of the phase 2 trials that ended up in New England Journal of Medicine and really got a lot of attention to this field. But could you say a little bit about what is it? What is the reason or the ideas behind these drugs? What is it they want to achieve, and how do they work?
I think to set the stage, it's really important to mention that this disease has actually 2 parts. So one is the lung part, which is, we call it a loss of function disease, which is basically due to the fact that we have too little of the alpha-1 antitrypsin in the serum. And then the liver disease is a gain of function disease. That means that basically all this alpha-1 antitrypsin is produced and gets stuck in the liver and kind of clogs up the whole liver. So this is why the augmentation therapy, which is the state of the art for the lung, does not really work, or not to a major way in the liver. So what we need in the liver is to somehow stop the production of this toxic protein. And the best drug, or the only compound that has positive clinical data, is called siRNA, which is a compound that blocks the production of on an RNA level. So it's not a classic gene DNA based therapy, but it's a therapy 1 level below the genes, and it stops the production. And the advantage...
Let me just stop you there for a while, Pavel, because this is a bit strange. Because this protein is needed in the lung, isn't it, Alice? So how does it add up that Pavel, he want to protect the liver and then reduce the protein that's supposed to protect the liver, the lungs? How does that work out?
So I think this is why pulmonary safety is going to be really important in the long-term trials of these drugs. At least in the short term, it may not make a large amount of difference, because we will effectively knock down the levels from low to very low. And once you are below a protective threshold, which you will already be from being ZZ, then there is still a risk to the lung disease. There have been small studies done comparing people with null gene variants, where they have no alpha-1, compared to people who are ZZ or ZZ. There are small differences in lung function. So there is a risk that if we give these drugs long term, we will make the lung disease worse. If you have augmentation therapy available in your country, you can potentially offset that by giving replacement therapy for the lung. And then we have 2 potentially expensive new drugs to be using in the same patient at the same time, which leads to difficult questions for health systems.
Yeah, let's first get the drugs, and then the next fight. But it's basically you need to protect both organs, because it's again a loss of functions. Are there more interesting new drugs in development you want to highlight here, Pavel?
Yes, so it's important to know that the siRNA is the only one which has positive human data. But of course, there is a lot going on DNA level. You can either completely knock out basically the gene with CRISPR-Cas, but there are also editing approaches both on DNA and RNA level, which would really switch the mutation back to normal, which would be a functional cure. So this is obviously
Functional cure, that's exciting. What is that you say? Is that gene editing, CRISPR thing, or what is that?
Exactly. So it's a gene editing, or it's also RNA editing. So there are different enzymes, some of them, for example, called ADARs, which can deamidate the one base pair, and kind of because of that, it's read as the other base pair. So this is basically the best genetic approach you can have, which really corrects point mutations back to normal. And actually, Alpha-1 is considered one of the poster diseases. That's why we've got our name, right, of the session. So if you want to actually kind of test this really trend-setting approach, then Alpha-1 seems to be one of the poster charts.
Could you highlight one, maybe you have talked, but do fill in other, do we have of ongoing clinical trials? You know, patients always ask for this and they're really interested to engaging in because they know the unmet need. So what trials do we have at the moment that patients can potentially enter?
I mean, certainly the siRNA study, which Pavel has alluded to, that's certainly up and coming. Other than that, others are in phase 1 and phase 2. But at this moment in time, I believe it's the siRNA is the kid on the block.
Alice, yeah.
Yeah, I agree with that. But as a pulmonologist, people keep approaching me to run Alpha-1 studies that involve liver biopsies because they're looking for liver outcomes as well as lung outcomes. So in my center, we will have 3 phase 1 trials, 2 DNA editing, 1 RNA editing in 2024. We will also have a phase 2 small molecule from company who've done lots of drug development in cystic fibrosis, and that's a liver biopsy outcome. And then we will also have the siRNAs. So loads to do. And I think unless we all share patients and let each other know, we're going to miss opportunities for our patients.
Can I add to that? And that's to say that I really concur with what Alice has just said, because if it wasn't for our connections in multidisciplinary work, particularly with pulmonologists, colleagues, it's the only way we're going to be able to really go on top of phase 1 to phase 3 studies. You know, collaboration is key to clinical trial development and serving our patients.
I think this is a very important message we can convey here, that again, if we want drugs for rare disease, and we do want that, we know that this is really difficult to recruit to. So we really need to stand together there and make sure that when this happens, then patients are referred to places where they can enter the clinical trials to support this. But now we're coming a little bit to an end. So this is a moving field where things really happen. But let's here end up with a question. I want you to dream and envision that all your best hopes for this field come true. And then let's say that everything is successful. What would it then look like in 5 years if you could decide and everything turned out positive? Or what is the dream scenario for our patients in 5 to 10 years? I don't know. You want to give it, Pavel. If you were, we are researchers, we are not God, but say that you could actually impact the future and all your dreams with this came true. What would it look like in 5 to 10 years?
I think the ultimate dream to me would be a very safe RNA editing therapy, because I always feel safer to interfere on RNA level than I feel to interfere on DNA level. And if you can really change, basically flip the mutated Alpha-1 antitrypsin back to wild type Alpha-1 antitrypsin, and you don't even need the weekly infusion. This is when I go and retire and enjoy my afterlife.
Wonderful. Aftab, what is your dream scenario for a patient given the same question?
The dream really is far early on and very early diagnosis and picking up patients much early, so that we can actually change the outcome and alter the course of destiny.
Thank you very much. And you, final Alice, what is your dream?
So, I mean, I think we've already outlined cure and early diagnosis, and we can't get any better than that.
Okay, then thank you very much for your time. I think it's been a very nice discussion. I learned a lot, and I'm sure those listening in also got some inspiration for how we actually give these patients a better opportunity for early detection and treatment. And then we're looking into an exciting future. Otherwise, thank you very much for tonight. And make sure that you tune in next Wednesday. Next Wednesday, we will discuss the impact of policy intervention targeting alcohol and obesity on the incidence of chronic liver disease and primary liver cancer through the HIPAA Health study. And as always, make sure you join the EASL family and become EASL member.